I'll be telling you today about two stories, and I'm hoping in 15 minutes I can bring them both together to create quite a magical ending. Meet Cheryl. She's 270 pounds, has a BMI of 45, and has a diagnosis of morbid obesity, a term I hate to use. She has type 2 diabetes, she has crippling joint pain, and she has severe asthma to a point where she can't even go up 2 flights of stairs without using her inhaler. Her 15 medications give her a constant daily reminder of just how ill she is. Cheryl wants two things. She wants to be less reliant on medications, and she wants to be able to get out on the golf course, something she has not been able to enjoy with her husband in over 13 years. Cheryl's not alone. The obesity epidemic is one of, if not the largest epidemic in history. And yes, I said history. A third of America already suffers from obesity, and a third of the world population will suffer from obesity by the next 20 years. Obesity is so large that we get lost when we try to calculate the costs. Every year, we discover more associations between obesity and disease, and the price goes up. But guess what? That's not the worst thing about being obese. The medical conditions are not the worst thing. The worst thing is that you are judged all the time. Cheryl experiences bias every single day. She is underestimated. She is underappreciated. She had to fire a physician because he was being dismissive. Obesity is one of the last forms of socially accepted discrimination. As a matter of fact, it's the leprosy of the 21st century. It's a medical condition that is used to justify bias, discrimination, and stigma towards people who suffer from it on a systemic level. And unfortunately, physicians, myself included, are one of the leading instigators of this bias. I asked a gynecologist for help with low libido. His response, lose weight so your husband is interested. That will solve your problem. This is not acceptable. And this issue is close to my heart because before I came to Medicine X, I internally blamed individuals with obesity for their chronic conditions all the time while I worked. And guess what? I was obese. I had a BMI of 30 and pre-diabetes, and I still blamed my patients for their problems. See, obesity is tough. It's frustrating, right? Society, physicians, insurances, they want us to believe that if you work hard enough, you can lose the weight and keep it off. That the 70% of Americans who have a weight problem or are obese, we're all lazy, right? But science for the last 15 years has actually been telling a different story, that our weight is the result of a complex interaction between environmental, behavioral, psychological, medical, metabolic, microbiomic, genetic, the list goes on. I can't get into the complexity of obesity as a disease today. But let's take it on a personal level. How many people do you guys know that despite having severe medical issues have tried to lose weight and just can't, or have lost weight even to regain it? Let's take a look at the diabetes prevention, right? The leading reason people come to Anara Health is I did everything right, and I still gained weight. Taking a look at the diabetes prevention study, this is again a program which a lot of digital health companies are looking to scale. At 10 years, what was the average weight loss? 2%. So even keeping 7% of your weight off is hard. There are invisible forces, biological, environmental, psychological, as a reason for weight regain. And the problem is we continue to hand out wellness programs, wearables, gym memberships, as if losing weight was easy and keeping it off was easier. This creates a vicious cycle of internalized failure, guilt, and a cascade of mental health problems. In this study, in people who lost more than 100 pounds and kept it off, 100% of them, yes, 100% said they would rather be normal weight than go back to being obese multimillionaires. And most of them, over 50%, said they'd rather be deaf or blind. So the stigma is that real. And we need a way better solution for it. Now, Cheryl wants to escape this burden. So for 10 years, she does do-it-yourself projects, right? She does low-carb that, Mediterranean this. She spends a year or 2 years in Weight Watchers, a year with Nutrisystems. And Cheryl's actually successful, which most Americans aren't. She goes from 298 pounds, that's her starting weight, to 270. And she's able to keep that 270, but she can't go lower, all right? And she needs help. So who does she turn to? She turns to healthcare. So what can healthcare offer her? So when we look at obesity treatment, we can split it into 3 boxes. The first box is programs like the Diabetes Prevention Study. These are educational, lifestyle, evidence-based programs. They get you about 6 to 7% weight loss. Weight regain is a problem, 2% by 10 years. The next category is the category I'm in, which is intense medical, behavioral, psychological programs. And these programs sometimes add medications, they sometimes do meal replacements, and some of these programs are pretty successful. They can get you up to 15% weight loss, but weight regain has been a problem, all the way down to 4 to 7% by the 10-year mark. The last category is procedures and surgeries, and the gold standard here is gastric bypass. Gastric bypass in the last 10 years has improved dramatically to the point where now we are getting sustained 29% weight loss at 10 years. People's diabetes goes away. Yes, it's a treatment for diabetes, right? Type 2 diabetes. And we just don't do it enough. Now, what's interesting is all of these are actually cost effective. Not necessarily cost saving. Only surgery is cost saving. So for all of them, you get good value for the money you spend. And in healthcare, that's measured by something called a QALY. A QALY is a quality life adjusted year. And generally speaking, if you spend $50K or less on a QALY, it's a good deal. As you can see, all of these are under $50K. What's interesting, though, is surgery, which costs up to $35,000, gives you each QALY for $6,000. Whereas something that's cheap, like the diabetes prevention program, you spend $400 to $600 per year on that individual, but your QALY is costing you $29,000. Now, the reason for this discrepancy for anyone who is in the obesity field is clear. Once you get the 15% weight loss, your life changes. It does, on many levels, okay? And you get so much quality back. Whereas when you just get 5%, your health markers improve a little bit, but in the end, weight is still the issue that you're chasing after, okay? So Cheryl turns to her doctor. Her doctor refers her to a program at PANF that's like the Diabetes Prevention Study. She does it for a year, doesn't work. What's worse is the wrong ICD-10 is placed there. It's not a diabetes code, doesn't get reimbursed, slammed with a $500 bill. Then her doctor refers her to a medical program. And that medical program, they tell her, hey, we'll cover your counseling visits, but guess what? If you want to do our program, you have to pay $1,000 a month for our meal replacements and our medications. Too expensive. She goes back to her doctor, explores some FDA weight loss medications. We'll get to those in a second. Not covered at that time. Then she finally does her research and signs up for a pre-bariatric program to get the surgery done. Again, she wants to gain her independence back, and they tell her, sure, we'll sign you up, but you have to do another year. Even though you did 2 years of Weight Watchers, 1 year of the Diabetes Prevention Study, you have to do another year of behavioral therapy before we give you your obesity. So this is fairly frustrating. Cheryl's frustrated. This is not her goal. She never wanted surgery. She wanted to find another way, but we're not giving her one. And this is my question. Are we all headed for bariatric surgery? Right? It's the most cost-effective. It's the one that's giving you the most for your dollar, and it's the only one right now that's sustainable. Right? Why haven't, or my main question is, why have we not been able to come up with a non-surgical solution for weight management and obesity? And it's twofold. The first is we're just understanding the science better. But the second one, and this is the one that I'll talk about in the second half of this, is that service innovation in healthcare is set up to fail. This is something we've talked about. Getting results cheaper is not encouraged. So let's start with reimbursement. At my own peril, probably to the wrong crowd, I'm going to summarize reimbursement in 2 steps. First is coverage. Insurance says, is this treatment effective? Yes, we'll cover it. Second is reimbursement. They set a price for it by saying, we're going to reimburse the cost plus some profit. Usually, this is based on an algorithm or some estimates from data. The problem we currently have is in American insurance, in America at least, insurances go down the line. Let's say this is the obesity toolbox. They'll go down the line and they'll say, we're going to cover this service, but they won't look at what else is in the toolbox. They make that decision in silos. So we're going to cover this toolbox, and then they price the intervention without looking at what else they're paying in that toolbox. Right? So everything is in silos. Right? There's no cost-effectiveness research. They don't look and say, well, we're paying this much for surgery, so we'll pay this much for this thing, which gives you half the weight loss. Right? And the problem with that is the first thing is it fragments care. This is why when you go into your doctor prescribes medications and refers you to things he doesn't know that you're covered for. You come back, you say, I wasn't covered. And the cycle, it's the hamster wheel, right? It's a hamster wheel of frustration. It's because everything is in silos, right? The second thing, which is very important, is it ignores the fact that interventions don't happen in vacuums. And this is particularly important for the topic of obesity. Who prescribes the medication, how they administer it, at what point in a program they administer it, when that intervention takes place, are all things that impact results but are never rewarded. And because they're not rewarded, no one has an incentive to build on them. And as a matter of fact, we don't see anyone doing this currently in the field. And this is at Inara what we're trying to do. Right? The last and most important is that it favors expensive innovation versus service innovation. And as a medicine doctor who gives mostly services, it's a pet peeve of mine. So for example, let's say company 1 produces a balloon in your stomach that helps you lose 12% of your weight. They can go to the insurance and say, it's effective, yes. It cost us $10K, we want $12K. Insurance will say, okay, we're going to give you a check for $12K. Let's say as a doctor I come up with a creative new way to see patients in clinic that drives results. I get great results, right? I get 12% weight loss. I only get my service costs, which on average, the margin on that is 5%. And in addition to that, building the program costs me a whole lot per patient. So I'm actually not incentivized to ever do that. Let's take a look at another example. The FDA recently approved 9, actually it's 10 now, 10 new either non-invasive devices for obesity or medications. And as you can see, these medications get you to the next step, from the 5 to 6% in the diabetes prevention study to 10 to 12% weight loss. And they're pricing it somewhere between 3 to 10K. And the reality is when you look at intensive behavioral therapy to get you to that much, it costs that much as well. So these companies are not pricing their product in a balloon. They sort of understand that matrix. What's interesting is Medicare recently came out with a way to try to encourage people to do the diabetes prevention study, right, program. And this was supposed to be a great thing for digital health because digital health companies were going to be able to bill for it. And what's interesting is they said, hey, 10% weight loss, we'll give you 25 bucks, right? And this is the problem. Medicare is just looking at the cost of what it takes to run a diabetes prevention program. They're not looking at the value of the return. So they'll say 5% weight loss, you get $335, which I actually think is fair, right? Because 5% again is easy and you regain quickly. So you shouldn't spend that much money. But you know, if you get the 10%, we'll give you an extra 25 bucks. And the problem with this model is it takes these companies and basically tells them, we want you to run the cheapest program possible to get the most people to 5%, and that's it. Don't go any higher than that, right? And they're not looking at what they're going to be reimbursing in the future. So they're actually, basically, it's not a system set up that's going to solve a needs for this complex epidemic. So we think there's a better model. Now, a lot of times with cost-effectiveness research, people say, we don't want to place a cost on human life, right? That's the common thing, like a life-saving procedure. But in surgery, we actually have somewhat of a gold standard. Gastric bypass, we know that at 20 to 30% weight loss, we're recuperating that money, 25 to 35K in 3 to 9 years. And then that patient is either being cost-saving or at least cost-neutral. Right? So if we take the most conservative estimate there, we can make a bold claim, which is as we tackle the obesity epidemic, for any personal weight loss journey, we should not spend more than $35,000 over 10 years. And that should include all obesity medications, labs, services, procedures, and surgeries. All right? We should not eclipse that. And if we take that, we will not only save money, but we'll get ahead of the curve But what we can do from that is come up with a creative way to incentivize companies to go out and create great solutions. And what I mean by this is you can come up with a tiered reimbursement plan over 10 years. Yes, 10 years, because that's what it takes to tackle weight. Okay? And that's what the data says. And you can basically say for 30%, we'll give you $35K. For 25, $30K. And then after 15%, the reimbursement drops off because we know, again, we're not getting the quality back. Right? And you open this up. Right? It's data-driven, it's outcomes-driven. Insurances have nothing to lose. And rather than everything being in silos, what it will do is it will bring pharmaceutical companies, digital health companies, physicians, surgeons, device companies together to formulate products. And so that way, when a patient walks in to get it, they know exactly what they're getting for. And what it'll also do is it will make these groups iterate faster, right? They're going to iterate faster, but they're also going to be cost conscious because that's what impacts their margin, right? And pharma and device companies will have to iterate with delivery costs in mind, something they never do. They're not going to come out with a $1,000 per month obesity drug, given that we should only be spending $35K over 10 years. That's out of the question. And everyone is risk sharing. And the best part is insurances actually don't have to deny any service. Any technology can be provided within any product as long as that group can make it work for them, that group or company, right? And that's the challenge. And yes, some will fail in this challenge, but what we'll see is we'll see examples of companies that are able to achieve the impossible, surgical weight loss results without the surgery. So at Inara Health, our goal is to take obesity services, whether that's treatments, medications, programs, and turn them into powerful services and beautiful products. And we think our technology allows us to blend medications, therapeutics, programs together into one seamless experience. And our first product, or one of our first products, is surgical weight loss without the surgery. And we do think we're going to get to this in 8 years, all right? And we think we can get there by creating a powerful digital and clinical experience that puts together evidence-based programs, services, therapeutics in succession or in tandem at precision moments, okay? Because the reality is when you intervene matters, and we plan to capture that and empower life-changing healthcare journeys. So how did this look like for Cheryl? Cheryl, before she had surgery, Cheryl met Inara Health. She attempted 5 to 6 successive/tandem programs. Some of them ran independently, some of them ran together. For her, it was just one experience, right? The first one was like the diabetes prevention study, but it focused on habits. And she lost about 20 to 25 pounds with that. The second was a medical weight loss program that included medications. She lost 45 pounds with that. And the last one was a redirection exercise to help her treat her binge eating, which was why she was never successful in the past. And Cheryl never knew how to paint before this. She learned how to paint in the last 8 months, and since then she has not had one binge eating episode. All right? And guess what? There's no reimbursement code for this. All right? She went from 14 medications to 4. She dropped 26% of her weight. We need 4% more and 8.5 more years left, and we will get the surgical weight loss. Okay? Her A1C normalized. Her asthma went away. Her pulmonologist called it a miracle. All right? And most importantly, she's back out on the golf course. All right? She's back out on the golf course doing what she wants to do. And Inara Health is thankful for the guidance Medicine X offered us. We are an everyone included company, and Dr. Chu and Dr. Caudry have guided us to make sure that not only do we design for patients, but that patients are our designers. Cheryl is a leading team member, patient designer, patient quality analyst, and she's here with us today. This whole process at 20 months cost $5,000. Now, let's give credit where credit is due. Cheryl had a great United Health plan, which covered about $2,500 of that. We expect that labs and medication cost another $1,000, but the money she saved on those inhalers far exceeds that. And Inara's contribution was about $1,250, all right? And this is over 20 months. And again, we think there needs to be a long-term model so we can stay connected with Cheryl, make sure she gets surgical weight loss without the surgery. And Cheryl's not alone. Our surgical weight loss product now is achieving 17% average weight loss and counting. We plan to get this to 25% over the next 5 years. And what we like to tell our patients at Inara Health when they come in is we say, look, getting healthy, getting the weight off, and dealing with obesity, it's not about the number of words you write or how fast you write them. It's about weaving those together to tell your story. And similarly, the obesity epidemic is going to be one of the most complex things we're forced to tackle in healthcare. And as actors in this space, we can either continue to act in silos and continue to ignore scientific evidence that says we need to be aggressive on this. But the reality is 70% of Americans are overweight. 35% of them are obese. And at least 15 to 20% would need something as severe as bariatric surgery today. So we're in the fourth quarter. We can either decide to be conservative, or we can come together as a cohesive family, take some risks together, throw a Hail Mary, and create one hell of a magical ending. Thank you.